Broadcast is now starting. All attendees are in listen-only mode.
Okay, you're all set.
Okay. Well, good afternoon, everyone. I want to welcome you to MTM's second in a series on leadership development. My name is Valerie Westhead. I am a physician, psychiatrist, board certified in psychiatry and addiction medicine. And I am still a chief medical officer and a CCBHC medical director, but I also do consulting work with MTM to support teams as they make changes, especially in their medical services, and most especially when it comes to figuring out how to break down the silos that exist within our organizations and help teams to work together. As I said, this is the second presentation of a series. If you attended a couple of weeks ago, you had David Lloyd, who is the founder of MTM Services, and his focus was on the skill development for those who are growing into leadership roles, moving from being what we categorize as a supervisor versus a manager up to being a leader and a mentor. So if you haven't been able to see that, you can look for that on the MTM website. David always supplies some exceptional insights into that topic, into many topics actually. So my conversation here with you today is going to be about siloed systems of care, which are rampant not just in community mental health, but in many organizations. So we'll touch base on a lot of things that contribute to that and some of the things that you can look at to change that, especially as a leader within an organization. Before we get started, I wanted to cover a couple of housekeeping issues. Number one, there are no CEUs for this particular series of presentations, but you will be receiving within a few days a connection so that you can get the recording and the slide deck of what it is that's being presented today and at all of the presentations in this series. It will also be on the MTM website, so you can direct people there who did not register. This will be sent to those who have registered for this particular webinar. During the presentation, if you have questions or have comments, please feel free to put them in the question box. We're not going to use the chat feature for this with the number of folks who are on this presentation. It just seemed to make more sense to use that particular feature. I am lucky to have Jody Gibbonet, who is our Director of Operations and Client Navigation, on in the background. So if anything goes awry, she will help us. But there will be time at the end for Q&A. So I was fortunate enough to get a few questions from people who registered, so I've kind of embedded them in the presentation and they might address some of the things that you're wondering about. So let me go ahead and get started with the slide presentation. If I can get it going. Let's see. So I wanted to start with what are the expectations that I hope you walk away from this with. First of all, understanding the importance of developing and maintaining multidisciplinary and multidivisional approaches in order for organizations to be successful. Identifying and addressing silos that exist in all of our organizations and hopefully identifying some of the barriers that are maintaining them so that you can do something to change them. And then how to redesign systems so that they will help you to create successful teams as you move forward. So I always like to start with the why of what we're doing, and I think it's important that we start with the organizational goals. CCBHCs, by their nature, are mission-driven. Our commitment is to the clients that we serve, to making a difference in our communities, and that is what engages our staff. That is what makes them committed to what it is that we do. So it's important that we create a workplace that feeds and nurtures those folks who want to work in this space. We know that now in 2022 and beyond, maintaining our workforce is a critical priority for all CCBHCs or CBHCs, excuse me. We have historically not been able to keep abreast with the salaries that are out there that we compete with, and that is something that is becoming a bigger and bigger issue for all of us. We also know that individuals tend to leave their leaders, their bosses, not the mission. When they move on, they often move on to another organization that has a very similar, if not identical mission. But they feel more valued. They feel that the work that's being done is done in a way that is more consistent with what the mission is all about. And organizations have to be financially sustainable. So a part of breaking down these silos has to do with making sure that what we are doing is something that we can get paid for and that we can keep the doors open for. So it's important also that we compensate our employees to the best of our ability for what they do, which means making sure that we're being funded at the level that we should be for the hard work that we do to meet the needs of our communities. So that's the organizational goal. So it's important that we keep that at the center and recognize that is why people work in the space that we work in. It's also important to recognize that more so than ever before, funding is really what is driving our care. Most of us are utilizing some wonderful grants that are out there from SAMHSA, from BJA, because the recognition is we have to have integrated care with the criminal justice system. State level initiatives, all of those things are out there, and most organizations are taking advantage of them. We know that prospective payment systems are coming, that value-based care is on the horizon. And as a part of that, we as organizations are going to have to assume the liability that comes with providing the care. We will have to assume some of that. So we'll have to really fully understand what is the cost of delivering services and what is it that we can do so that folks do not penetrate into that higher level of care. And that means getting them into services rapidly, making sure that they have the right services being provided when they need it, and that we are measuring how this is happening and how clients are progressing and improving so that we can demonstrate for these funders that we are in compliance with what they are looking for. If we do it well, if we figure out how to work within these new systems, our revenue streams will actually increase, and that is what will make us sustainable. Ultimately, what this is driving us to is that de-siloed integrated care approach that is been talked about for the last 20 years in healthcare in general. So that is my segue into making it very clear that CMHCs are healthcare systems. And I think sometimes that isn't necessarily on the forefront of people's minds. We are working with chronic disorders of the brain. All of these chronic disorders of the brain interact with other medical conditions. And any care for chronic health conditions requires multiple individuals with multiple specializations and different competencies to achieve the positive outcomes. No one with diabetes just goes to a doctor and gets a pill so that their blood sugar comes down. They see a dietitian so they can learn how to eat better. They may see a physical therapist so that their physical agility and their ability to get some exercise, which will improve. They often see a therapist or a psychiatrist or a nurse practitioner to get medication because of the anxiety and the depression that goes along with this. And there's usually services for families as they try and wrap their head around about this significant change that doesn't affect just their family member, it affects them too. Because funders are looking at that shared risk, we have to make sure that what we are doing is within a healthcare definition, efficient, effective, and has those improved outcomes. We are ultimately going to be responsible for how we do that and how we do that well. At the end of the day, it's really about creating that true safety net that we all describe ourselves as being. We usually are the safety net to meet the needs of those who are either have no insurance or on Medicaid or are underinsured and need the level of care that we can provide. That is, of course, the big driver behind the CCBHC model that is out there. It's important that we look to both internally becoming integrated because we have to be co-occurring competent, trauma informed, and use active care coordination to meet the needs of our clients. We need to make sure that we are engaged in effective community partnerships because we have to collaborate with primary care. We have to collaborate with specialty medical care, and we have to address the social determinants of health. Sometimes what I'm seeing a lot of is organizations are being asked to take that on as another division, so to speak. How will you as a mental health center help me with my housing, with my unemployment or my underemployment? That is not necessarily in our wheelhouse. There are some projects that are out there that we can get funding to help with reaching to the homeless and what have you. But social determinants of health have to be something that we are team-based with our community partners around, because we need to focus on our areas of expertise, and we need to work with other partners who have areas of expertise outside of our own, so that we are truly treating the whole person. That is what is being expected of us. That is what the systems of care and the funding is driving us to. And at the end of the day, that's really what our missions drive us to. Our missions are about meeting the needs of the whole client. So that brings us to question 1. And this was, I took a couple of the questions that were sent in with the registrations and kind of incorporated into this first question. How do we take efficient and effective departments within our organization, because we are a multi-departmental organization, and have them work together? And the comment that was added to one of those questions was, we struggle with communication and hierarchy at my organization. I would imagine that those 2 statements resonate with many of you. So my first question back when I read it was, are we really effective and efficient if we aren't truly collaborating with the other departments? Because if we're not collaborating with the other departments, we aren't going to be very successful at achieving our organizational goals. We might be doing a very good job within our OBOT clinic of clients following our expectations and engaging in getting their medication. But if we aren't working with the clinical team that's providing the intensive outpatient program and they're not going for that, we're not doing our best job. We may be doing a great job in our billing department and getting those bills out and making sure that they're going out in a timely manner, but are we actually making sure that the providers understand how to select a CPT code? Are they selecting the right ones? Are we sending out what we need to so that we will maximize the revenue to pay for the hard work that's being done? And the question is, who is maintaining those barriers? Obviously, there's barriers to this. Is it truly the leadership? Is it the teams that are involved? Is it both? And I would tend to think that it's both. And it could be some strategically placed people who just don't necessarily see that we all have to be playing in the sandbox together. So one of the most important concepts that I think I hope everybody walks away from with is that CMHCs are group practices, group healthcare practices. We are not loosely affiliated solo practices, so we can't have 5 nurse practitioners and a psychiatrist all doing things in their own way. We are not departments that are just internally whole and in and of ourselves, but we are collaborating, we are working together. So there has to be true standardization. It can't be, well, we do it this way in this particular county, or we do it this way within the clinical services, but not in the medical services. How do we pull those things together? How do we come to that standardization? How do we identify what are the best practices that we are already doing? There are, I am sure, a number of best practices that are taking place in small ways and in big ways. And how do we take those and implement them system-wide? And how do we look outside of our own organization and identify group practices that would be a benefit to us? That is how we will truly create effective workflows. And we will get to that point where we are maximizing our revenue and lowering our costs. So it's important that we recognize as a group practice, anything that we do in one area of the organization impacts everybody else. And I tend to think of the 3 divisions that we have within CMHCs as being administrative, clinical, and medical. Please note, I put them alphabetically. None of them is more important than the other. They all rely on each other. And if we don't work collectively, we are not going to do our best for the clients we serve or for each other and making the environment a place where we all want to come to work. Do we use tools and workflows, and are they in alignment with each other so that we can be effective, so that we can actually be successful in working as a group? So those are some questions you should be asking yourself and your teams. And these are questions that should be asked from the top down to the very bottom, the boots on the ground, because that is essential. Group practices by their nature are de-siloed systems. They're very team-based. And when I say team, I mean both vertically and horizontally. And we'll talk a little bit more about what vertical and horizontal integration are all about. But basically, vertical integration is your department. I put up the examples that have to do with the service delivery side. You know, within service delivery, we've got the clinical, where we have therapists and case managers and peer supports. And depending on the client's need and depending on the availability of staff, clients can receive services from one or all three, and we determine who will provide what components of the care. Same is true within medical services. You have a nurse practitioner, you have a physician, you have a PA, you have nurses, LPNs, and MAs. One of the teams that I've worked with has a very elegant system in their medical services where they have, when a client checks in, they first see an MA because those are not billable services. So they get checked in, they start some of the paperwork. They're then roomed to see the nurse practitioner, all of whom are not on site. All of them are in the same state, but they are not on site, and they are seen via telehealth. The nurse, you know, the MA usually brings the person in so that, and lets the provider know that they're ready to go. Provider performs their intervention and services, and then when the client leaves, they are met by an LPN or an RN who does a post-visit, which is a billable service in that state, so that they are able to maximize the skill set of everyone, and they are able to maximize the time that is spent with each individual, so that we can be, excuse me, very efficient with the provider time, which is the most precious because we only have so much of it. And then the nurses and LPNs and MAs, who are a vital part of the team, are also doing their part to wrap services around that client. That's what we mean when we talk about vertical integration. Horizontal integration is really what the de-siloed system is all about. It is really talking about working as one treatment team. One treatment plan drives what we're doing. We are using those multidisciplinary care pathways. We are using multidisciplinary treatment teams. We are using check-ins with each other so that if a case manager has a question, they have a moment to talk to the nurse practitioner, or the peer support person can actually give some information to the therapist about what they're seeing when they're meeting up with the person in the community. It is about making sure that we are having all of those interactions so that we are doing our best for the clients. And we are using tools to measure that. We are using things like the, Columbia Suicide Severity Scale, the GAD-7, functional assessment tools like the DLA-20, so that we can really be monitoring and demonstrate for the clients and for each other the effectiveness of what we're doing, and ultimately making sure that the funders see what it is that we're doing. So do you know what each other does? Do administrative, clinical, and medical services truly understand how they function, how each one functions? And are we making sure that the system we're building is actually going to be compliant with these new payer models? How are we doing with regards to the strength of the team? And that's going to be my mantra. You'll hear it a couple more times. So expected outcomes of a de-siloed system are what you see right now. We want to make sure that our service is measurable and meaningful to the clients. We want to make sure that they can get to care quickly. We want to make sure that the health indicators that we are measuring are actually showing improvement. And we want to make sure that they aren't deteriorating to the point where they need this higher level of care. We can't prevent it for everyone, but the more quickly we can get someone into care and the more integrated that care is, the more likely it is that we will keep them in the community and functioning at their highest level. De-siloed systems create that strong team. The team is what really matters, and it creates that shared sense of responsibility and improved accountability. And at the end of the day, that is how we retain staff. That is how we have staff satisfaction, and that is really an important goal for all of us these days. So that is the why, and I think it is really important that we are all clear on the why, because in order to help people to get to the place where we're willing to change, we need to have an understanding of there are important reasons behind this, very important reasons behind this. Because change is hard. Those of us who are on the service delivery side know it on a daily basis. When we are working with our clients, trying to get them to make some changes can be very, very difficult. It is not easy to help someone understand that what they are doing is a part of what keeps them stuck. And the same is true on the business side. The same is true within our departments. So we really want to make sure that everybody understands change can be painful, change can be exciting, but change is uncomfortable no matter what angle you're looking at it from. So that kind of brought me to question number 2. And this again is kind of a question where I pulled together a couple of things that were that came from individuals who signed up for this webinar. And it was about how exactly do you build this team? And there were a couple of questions about, especially when we're in a telehealth world. We're not all in the same building. We're not all in the same place. Sometimes we're not even on the same time zone. So it is about how do we create that? And I'm hoping as we go through the next set of slides, you will get some of the answers to that. Obviously, we have to learn how to talk to each other. We have to learn how to create meetings that are on things like this, GoTo and Zoom and on Teams, that are engaging, that do promote discussion, that do get people to share their ideas. And that's something that is a skill that we need to get better at, all of us, everyone, whether you're leading the discussion or whether you're a team member who should be giving input, because your input is as valuable as anybody else's. So all of our houses are divided to a greater or lesser extent. And it's critical that we really look at understanding how siloed is our system. I see quite often medical and clinical services are kind of spinning along, doing their own things, and they really don't talk to each other. They really are not having those collaborative conversations. I don't know if that resonates with anybody on the call. I think there's been a lot of feelings over time of you know, they don't understand what I do. They don't appreciate what I do. They want to tell me what to do. This is the kind of thinking that we have to get past. Do your clinical director and medical director, whatever level they are, whether they're at the chief, the director, however you have them in their organization, are they connected? Do they communicate? David Swan, who'll be doing a presentation later in this series, uses the phrase, they should have no light between them, which means that it doesn't necessarily state that you're going to always be in agreement, but when a decision is made, however that decision has come to, they support it uniformly. So it's making sure that that happens at all levels within your medical and clinical services, so that you do have that shared understanding of what we're doing and how we want to move forward doing it, and how we will modify it if what we've decided isn't working. I grew up in an era when I started as a resident where mental health and substance use providers were in totally different camps. I'm happy to say that we are not in that same space anymore, but I don't know that our educational systems have caught up with us. I'm not convinced that in the master's level programming, and I certainly know that in medical school and in residency, there is not an equal engagement and training around mental health and substance use disorders. There may be more of one or the other. So our staff, and we frequently are the first stop after someone gets their degree, finishes their residency, has their master's degree, working toward licensure. We are their first stop, usually. We are what I call the residency program for all of those early career folks. Our goal is to make this something that they want to do for forever. And if they don't, we want to make sure that they have a positive feeling about us so that they will support us in the work that we do as they move on to other activities. So you want to make sure, are your staff really proficient? Do they feel comfortable? If not, what are we going to do to help them to get to that place? We want to make sure that all of our staff feel confident that they can work with the whole client, that they understand how substance use and mental health interact with each other. And then our service delivery teams and our business management teams really understand each other. You know, a lot of times there's a great discomfort in sharing with service delivery teams, you know, it costs this amount to keep the doors open. And in order for us to do that, we have to make sure that we're bringing in this amount of revenue. Those are not bad conversations to have. I think they're critical conversations to have. We also need to have administrative teams and the business management teams hear about what it is that we provide. What is it that our deliverables are? Because that's an important understanding so that they can understand how maybe some business practices need to be modified to work effectively with what it is that we try to do, or trying to figure out how our revenue streams need to really be tied to the specific activities that are going on. And I wouldn't be fair if I didn't say something about productivity, because I think productivity is a buzzword that can be felt as if it's a weapon or a threat, and it's not. It shouldn't be. Productivity is just a word that helps us to talk to each other about making sure that we are doing this collaboratively, that the tools and processes that we are using are effective. It is not saying someone is doing a bad job. That may be in a small percentage of the cases. What we have to do is figure out why one individual isn't as efficient or as effective at providing the care that we are as a group practice trying to do. It has more to do with what are the tools that we're providing and the processes that we have that may be maintaining a low no-show rate. Or a high no-show rate, depending on what it is, so that we can make sure that we are using our most important tool, our providers and our clinicians, to effectiveness. So the question is, are you ready to make the changes, and are you ready to do it in a stepwise fashion and give yourself enough time to do it successfully and well? This is just a series of questions that you should be thinking about. I'm not going to read through them because that would, number one, take too much time, and I don't think that's an effective way to engage you. But the things that are highlighted in blue are some of the things that are most important. Is your workforce, is your leadership all about lifelong learning and understanding that evidence-based practices change? They change over time. New business practices, new business approaches, new ways of treating specific conditions, new medications that come along. Are we all in agreement that things are changing in our world and will continue to change? Are we measuring what's really important to the client and to the success of the organization? Do we recognize that everybody, including the client, has a role in the accountability and success of what is going on for that individual? High quality care is something we all have to work on. And do we communicate with each other? Do we know how to communicate with each other? Do we speak the same language? And I think one of the first language things that we can do is really identify what it means to be solution focused. There is an evidence-based therapy called solution focused therapy. And that's the definition that I have up there. You know, in solution focused therapy, we are directing patients toward their future, not looking at their past as much. We are looking at their strengths, and we are trying to build on those strengths to make their future what they want it to be. And that's not a bad definition for what we want for our organizations. We want our organizations to identify what are the strengths that we have, what is it that we need to change to make better, and how we take the strengths that we have from wherever in the organization to move ourselves forward. The only way to become solution focused is to really be willing to start with a fresh slate. That means the things that might be the baggage from the past has to be taken off the table, and we have to understand that in order for change to happen, we have to keep ourselves focused on the goals that we all agree to. We want our clients to be stable, to grow, and change in a positive direction. We want, as a workforce, to be engaged and enjoy our jobs and feel that we have a purpose and are making a difference. And we need to make sure that we can keep the doors open. When you come down to it, those are the three things that we need to be keeping our solution-focused thinking all about. A lot of organizations use the phrase a new day and a new way. And that really is what change is all about. It's critical to realize that a new idea can come from anywhere and anyone. So when you are talking about how do you build your teams, that is why it's critical that your communication and engagement is in a format that gets people to connect and to start to think about things. And that means asking employees to keep an open mind, asking employees to actually read the things that are put out there. I know most organizations send out emails, provide newsletters, have team meetings, but if the staff aren't reading the things that are being put out, are not following through on the things that they're asked to do, doing those Reliance trainings, we are not going to move forward very quickly or very well. So it is making sure that we set that as an expectation and that we make sure that staff understand it is through those avenues that we want your feedback. And we have to be open to accepting that feedback. And even if an off-the-wall idea comes from somebody, that can actually be the small little genius moment that can take things into a totally new direction. And it can come from anyone. And my personal favorite, this is one that I do all the time, is that anytime that I'm working on making a change, or if someone says, I don't know, this is a big problem, Dr. Westhead, I will say, I think you're right. So what are 3 ways that you think we could address that? Because everybody in the organization has got to become solution focused. And I know if someone's bringing me a problem, they've thought about it enough that they might have thought of some things that I wouldn't think of because I'm not looking at it from their vantage point, that could make a difference, or might make me think of something, or we might take it to the treatment team and say, everybody agree this is a problem? What can we do about it? And as you do that, your teams will begin to see that our team meetings are really all about moving forward, not just, just a very rote presentation of information, but it's really about having a dialogue and having a process for moving forward and improving things. We're back to that vertical and horizontal relationships. This is where we have to really understand how we cross boundaries and build those connections. When we talk about vertical relationships, we're really talking about department, or I think of it as your tribe. These are the folks that you feel most comfortable with because they do what you do, or do things that are very much related to what you do. They can be very site specific. Many organizations are now growing through mergers, as not every organization can survive independently. And when they do that, well, we've always done it this way at our organization. Oh no, that doesn't make sense. We've done it this way. So there can be a lot of tribal miscommunication and sometimes distrust, so that we have to find a way past that. We need to make sure that someone who is in a leadership role in the vertical sense has good technical skills, has a good understanding of effective processes and what are the workflows. But vertical relationships are all about that internal department. Are we doing well in medical services? Are we doing well in our therapy department? Is peer support doing well? Is the billing team got what it needs? Is the call center able to handle all of the calls that are coming in? Those are the vertical relationships. And those are the ones that we tend to spend a lot of time on, in part because they're comfortable. That's where we feel strong and confident. We know what we're doing. What's really the challenge is looking at those horizontal relationships. And that gets us back to, we are a group practice. We want the best outcomes, and the best outcomes are going to come if medical services are talking to the call center, because we now have clients calling in to make their appointments rather than making appointments when they leave their last one. The call center is affected by that. So if we aren't talking together and figuring out how we can support each other, that is going to fall apart. So the best outcomes for any change is going to require that teamwork. Any change affects every part of your organization, and that has to always be what you're thinking about. Standardization in order to be most efficient, and then making sure that we identify who are the experts within our organization. Do you have a couple of people that know how to do EMDR? Well, can they help other people to understand what EMDR is all about, identify who should be referred to EMDR, and maybe encourage folks who would be good at it to go get the training to do EMDR, just as an example. It's making sure that we are making those experts available to the entire organization in any way possible. Identifying that different departments doing things different ways can actually support each other in making significant changes. Business functions are often very highly organized and very tightly connected. How can we take some of that and put that into how we connect medical and clinical services? What do they do that might be a benefit in there? What are we doing for staff development and growth? We want to make sure that we are developing different staff in different areas and let them know that when they get sent out to a training or do a specialized thing, we are looking for them to come back and be the expert and be willing to share that with other folks. Another organization that I am working with has an annual 3 or 4 days of training opportunities that are provided to everyone in the organization. And everyone is asked to attend 3 of these 2-hour trainings. And then at the treatment team or the team meetings that happen after that week of training, it is expected that everyone will share the pearls that they gained from those particular sessions. Because you can't have everybody attending everything, but you can have everybody become an expert in important things so that we can, whoops, sorry about that. There we go. We want to make sure that everything that we're doing is improving client outcomes and the strength of the organization. Horizontal relationships are what will accomplish that. That is also what will support innovation and create value. We're talking about funders now. Funders will see that a client, when they are asking for records to look at, oh, look, the therapist is talking about this. And guess what? That nurse practitioner is talking about the same thing. And I can see where they have reviewed each other's records and they are making sure that they are reinforcing the important things that this client should do in order to get better. That's what creates value. And it's important that we look beyond the organization. Horizontal means outside of our four walls, but into what are the new trends? What is going on out there that could help us? What are the opportunities that we need to be aware of? What are the threats that we need to be aware of? And who are the folks that we need to engage with in order to meet the needs of our clients beyond what we do as an organization? So horizontal relationships are much more complex. They can feel overwhelming because it's not our comfort zone. But that is what it will take to take your system from its current level of siloedness, which may or may not be a word, and take it to that de-siloed, integrated, no boundaries that are preventing good client care. So if you did attend David's seminar, webinar 2 weeks ago, he talked about 3 levels of leadership, and the titles are arbitrary, but when we look at someone that we think of as a supervisor, that's someone who's a problem solver. That's someone who is reactive to things. They look backward to how do we solve this. They're very vertically focused. They are really committed to what is needed by the department. That is their level of strength. That is what they are focused on. And they are there to process crises and give attaboys when things are going well. So supervisor is very much focused in that first level of vertical connection. The goal is to help that individual kind of transition to being what I'll refer to as horizontally inclined. They're beginning to see, oh, I was talking to so-and-so over lunch, or I was at training with them, and in a break we talked about something, and I thought they had a really good idea that would help me solve something. So taking advantage of those natural opportunities that will bring you into contact with someone outside of your tribe. A manager, and again, you may call it something else in your organization, but a manager is someone who is starting to have a lot of proactive, solution-focused decision-making skills. They are becoming more horizontally aware and inclined, and are in the process of at some point becoming horizontally focused. They are generally pretty good at a project management level. They can look at what needs to happen within the division where they are primarily working and how that should integrate with another division so that the project can be completed and done well. They can manage more complex problems, and they recognize that different skill sets and approaches are needed in order to be successful. A manager, by their very nature and what they're doing, is committed to the group practice. The supervisor is still very committed to their space within the group practice. A manager is starting to see this is a group practice. A leader, coach, mentor, whatever level they are, is someone who is able to maintain and sustain true change and recognizes what it takes to survive in the marketplace. They are completely horizontally focused. They're aware of what happens in all those vertical, hopefully no longer siloed systems, but their objective is to understand how to make all of those pieces work together. Just like the Lego sets my sons used to put together, you have to put the pieces together in the right way for it to look like what it should look like and to function the way that it should function. Leaders are driven by those internal pressures, those internal needs, as well as the external realities. They are fully aware of all of the things that will impact the running of this organization and how it will be successful. That's where you really get to being what we would call a boundary spanner. someone who has great technical expertise, and quite often they have expertise in more than one discipline. Taking myself as an example, I'm a board certified psychiatrist. I'm also board certified in addiction medicine. And in my residency, we did a lot of therapy. We were trained by psychoanalysts and we did family therapy. So I have some expertise. I haven't done therapy per se in a long time, but I have a good understanding of it. So I have technical expertise in more than one domain. Many of your staff have technical expertise in more than one domain. So it's important that we recognize that. And that we take advantage of that. Someone who's going to be a boundary spanning leader is going to be someone who has well-developed interpersonal and social skills. They have a good self-awareness and a good ability at self-correction. That is something that it is not really easy to teach. It is something that someone generally brings to them with them when they come to your organization. Some folks can get to that place, but you want to make sure as you're identifying your future leaders, do they have that ability to recognize their strengths, recognize what they should be working on to do better, and then be able to correct themselves as they move forward. They have to have empathy. They have to recognize what others might be thinking and feeling and experiencing. That's what you need to create that environment of open dialogue and support that makes it possible for people to express their ideas. They need to know how to engage and solicit input. So they have to listen more than talk quite often, and then synthesize that and be able to communicate it to the group so that we can actually work as a team. And they have to be able to motivate and provide effective feedback. There's some great articles at the end, some of the things that I would recommend that you look at. Another thing that I am is I'm a psychiatrist who reads the Harvard Business Review. Why? Because that gives me some really important ways of looking at how to work within my own organization and hopefully support other organizations. And in the most recent Harvard Business Review, there are some great articles about exactly these elements and actually the awareness that as organizations are trying to identify leaders in whatever sector they're working, they're looking to find leaders who have these interpersonal and social skills. You also have to have curiosity and humility, and those are kind of two sides of the same coin. If you are a lifelong learner, meaning you're curious, you're interested in looking at things from different angles and in broadening your vision throughout your career, you already have a fair amount of humility. You're already saying, I don't have all the answers. I'm curious to understand what is out there. What are other ways to do what I do? You're interested in what is happening on the business side, in what the therapists are learning, in what are the newest medications and how do they affect clients. We are looking at how do we come to solutions centered around similar processes so that we can then be able to bring our own unique requirements of what we do and attach them to that. And it's important that that they know how to ask the right questions in the right way. You want to ask them with a clear positive intent that you really want to learn and you want to understand, how can I be a part of this team moving forward? Asking questions like, how did you accomplish that? That was pretty incredible. Or, I saw this working. What do you think worked? What do you think didn't work? What might I be able to do to help you? Most importantly, how can we collaborate in a better way? So it's about having these skill sets and encouraging people to be vulnerable enough to be curious and to ask those questions and to be able to provide answers when questions are asked of them. That's what we need to be looking for in our leaders moving forward. They ultimately function as culture brokers, and that's another phrase that I took out of a Harvard Business Review article. And culture brokers have two functions. They have a bridge function, which means that they have enough knowledge and expertise in more than one domain so that they can kind of speak to two silos. The advantage to that is as you're moving in your change process, that is the person that can minimize the day-to-day impact of changes because they understand what's going on both sides. They can be the go-between. They can be the interpreter. They are the person who can help get that cross-silo input started. They're building that possibility of connections and relationships. So you want to identify who has that skill set and who has some of those personality traits that I just described. In addition to having a bridge function, they have to have an adhesive function. They have to be able to connect people and keep them connected. As I said, they are an interpreter. They are the folks who bring those teams together, who are able to have those dialogues with different people in the room and make it an effective conversation. So we want to be looking for those who can perform that, who can grow into that role. I just wanted to throw in a couple of examples of how boundary spanning can really be a significant issue. I know everybody on this call works with an electronic health record. An electronic health record is an important tool that has multiple users with very different needs. If we aren't using boundary spanning approaches when we talk about how do we select it, how do we implement it, how do we upgrade our electronic health record, then we are not using the best tool possible. We want to make sure that we are understanding what is needed on the business end, on the KPI end, on the tools end for those who are inputting into the system. And how can we collaborate internally to obtain the best customer service that we can from our vendor? Another perfect example, again, that I'm sure everyone on this call has experienced is no-show management. How do we define the problem? On the clinical side, clients aren't getting care. Clients are being denied access because someone else took an appointment and then didn't show. On the business side, revenue deficits, financial risks. We're having, conversations, but they aren't always conversations that happen together. Developing the solution is something that needs to be done as a team as well. Do we change how we schedule? Do we change our hours of operation? Do we change the types of services? And how do we make sure that we make these changes that will have an impact agency-wide? So those are two, I think, concrete examples of how boundary spanning, de-siloing the system can and should happen. How do you reorganize yourself? You can look at creating kind of a matrix management where you are having individuals who can work at that interface, those culture brokers who can start that process for you. You can have crossover leadership, which can get a little difficult because there can be some bristling. If you have a nurse who's got more of a leadership role of a clinical program, or a medical director versus a chief clinical officer, but that doesn't mean that you can't have that as long as you build those relationships over time. Truly, the most ideal is to have a co-leadership kind of approach, regardless of title. That is that joined at the hip, no line in between, and it should happen at all levels between different divisions. That is how you're going to eventually have your culture of collaboration and connectedness. We want to make sure that the business plan that's created for success, which is, by the way, for those of you who are clinical, a treatment plan for the organization. When we talk about business plans, we're talking about goals, objectives, and strategies. Well, that's almost the same as when we're talking about a treatment plan, because we have goals and objectives and interventions, which can also be called strategies. So it's really about recognizing we are doing the same things, we are just doing it in a different venue. And that what we do, how we learn to create a treatment plan on the clinical side is very similar to how we create a business plan, and we can talk about that collaboratively. We need to identify where are the areas that should change and what should we attack first, what should be our targets, what should be our timelines, because if we don't create timelines, we will never do it, and what are our accountabilities to get it done. We want to make sure that it's always purposeful and intentional. And we want to be honest about what are the positive and negatives about this. We know that as we make changes, we're going to be budgeting resources in a different way. That means people may be doing different jobs or interfacing in a different way. Facilities might be used differently. The tools might be used differently. And where are we going to put the money? Where is the capital expenditures going to be? And how will that make sense for the overall organization? So I kind of put this in just to make it clear that we are looking at the same kinds of issues with the same kind of advantage. We just don't always think that we are. If we focus on customer service, we will get to the place where we need to be. The first statement is kind of one of my things that I think is important. The customer is not always right. Our job is to kindly and respectfully offer them what they need based on our expertise and our assessment. That is what we're here to do. Clients and their support systems need us to do a comprehensive strength-based evaluation and problem identification and provide them with evidence-based recommendations. What about our customers within the organization? We are each other's customers, and we don't necessarily recognize that. Our colleagues in other divisions and other departments are people that we should be recognizing as someone we are providing a service to, because we are working together as a group practice. And community stakeholders. Community stakeholders, and I think this is something that we don't focus on in the right way. We need to be very focused on collaboration to address whole health needs. We need to understand that we can present what it is that we do well, and we need to establish the understanding that there are bi-directional boundaries, responsibilities, and expectations. Our role as a client and behavioral health care advocates in establishing parity and access to care is one of our most critical roles there, but we also need other organizations to do their part and to engage with us in the way that we need them to, so we can do our jobs well. That kind of brought me to question number 3 that was in the registration. It was, what are 2 things that can be done to improve integration with community partners? Great question. I came up with 4 as a starter. I'm sure there are many more. But one of the first ones is to figure out who are the power brokers in your community. I can tell you, in my home community, the power broker is really the sheriff. The sheriff's office is the most powerful entity in the county, and that's who we engaged with many years ago and have worked collaboratively with to create many good things. And that brought on the school system, that brought on county government, that brought on other providers of other services, so and homeless outreach programs. But it's, who is it in your community who has the voice that can get things done? You want to make sure that you are participating in any kind of task force that is engaged in mental health, substance use, criminal justice system engagement. That's critical. We all know that many of our clients are getting their mental health care in the jail system. We want to pull them out of there. We want to do our part to make sure that they don't penetrate further into that environment. Involved in prevention and early intervention programs. That means we engage with our community partners, find out what they're doing, let them know what we can bring to the table, and create those things. And I think the final one that came to my mind is working with our trade organizations, because they are the ones who are going to advocate the most. And we need to give them our input, and we need to take their message back to our communities. So those are some things that I think are critical in that horizontal viewpoint, that it's not just within our organization, it is actually far and away outside of it. I'm going to end my last kind of comments on the fact that communication is what I refer to as a team sport. We've got opposing sides when it comes to communication within our organizations. Human nature. Resistance is going to be there because there's a lot of concerns about, what will this change? Will this really do things better for the client? Will this really make my life more difficult or easier? And will this actually help us to engage with communities? We want to make sure that our language is fair and honest. These are quotes that I have from organizations that I have heard. We've always done it this way. Well, what you've always done isn't working. So we need to take that one off the table. The most undermining is the second one. I'm sorry we're making you do it this way. I don't like it either. Direct quote. Change is necessary for survival, but that is the pernicious resistance that will undo what you are trying to do. And it's okay to say it exactly that way. We don't want to undermine each other. If you have a concern, put it on the table. Let's talk about it. And then, you know, that kind of, people in administration don't even know what we do. Don't these doctors and therapists understand we are business and need to make money? What have you done to actually improve that communication? What have you explained? What have you shared? Everybody on those 2 sides of the equation are responsible for improving that. The team sport can be a positive for everyone when we use the phrase we, starting with we, at whatever your organization is, are making changes, action, to better meet the needs, action, of the clients we serve, action. It is about we and the actions we're going to pursue. So that brings us back to the 3 learning objectives that I had at the beginning. Understanding why you need this kind of de-siloing, multidisciplinary, multidivisional approaches. What kind of silos do you have, and how will you address them? And how can you redesign your system so that you can do these projects with fidelity? Changes are hard. we have to keep our focus on the prize. What is it that we're trying to do? We're trying to meet the needs of clients. We are trying to have a workforce that is energized and excited and wants to be there. And we want to make sure we can keep the doors open. We know that when we make these changes, that can be disruptive, but that engagement acceptance is going to have to be what we focus on. And we have to communicate honestly. Here's a list of resources. And as I said at the beginning, you will get these resources when you get the slide deck. So I'm going to open it up to questions, and hopefully I can do this part correctly. So let me look. There's a hand up. Let me see if I can do that. Or the questions. Let me look at the questions. Let me make this bigger. Okay. I think those are presentations. I think those were things that we already addressed, all of those things on there. So let me go to the attendees and see if there are hands up. I think Mary Ortiz, let me go ahead and unmute you. And please go ahead and ask your question, Mary.
Yeah, you answered the question already. Thank you.
Okay, you're welcome. I'm glad I could do that. Okay, Cynthia O'Neill, I think you have also had your hand up. I wonder if you wanted to ask your question.
Can you hear me?
Yes, we can.
Okay, thank you. A great presentation. Thank you so much. A quick question. Are you aware of any documented case studies that talk about community partnerships that have been successful? So when you think about collaboration across health systems, anything written out or in a journal somewhere that kind of talks through examples of community partners that have been successful?
You know, that's a great question. I don't know that I have any particular ones that come to mind, but I can speak again from my own experience that the best place the best way to make that happen is to decide what it is that you as an organization are going to do, how you want to set up your system, what you need to do to be successful, and then go out and let your community partners know about this and ask how they believe they can actually engage with you with some specific expectations on your end. What I can do is I can see if I can find some out there that are really all about that community partnership that could be very helpful. I personally did a lot of work by going to our local task force that brought a lot of community partners together. And I actually took the step many, many years ago of offering to be the psychiatrist in the jail. And I did that for about a decade, in addition to working at the mental health center, so that we could have sort of a shared understanding of what the needs were in the jail, what could be done when they left the jail, and how could we partner better. So it is, I think, looking for those kinds of opportunities that exist in every community, and being willing to stretch your organization out a little bit to give something that you have to give and say, how do we get this to work together? Another natural space to work on, because I think the criminal justice system is a big space where we need to work together, is talking to them about reentry programs. That is a natural fit where what they're doing in the jail and what you are doing in the community can come together. Or working specifically with hospitals around their discharge planning and making sure what they are looking for is consistent with what you are able to provide. But I will see if I can find anything and have it put up on our website at MTM on that particular issue.
Thank you so much.
Anybody on the call who has some other experiences that they could share on that, where they've been successful? I can open you up if you put your hand up. Well, I believe we've hit our 1 hour mark, so I hope this was helpful. As I said, you will get the presentation, you will get the recording, and please feel free to send your questions to MTM and we will try and get back with you. My email is on there, so I'm happy to take any questions that you might come up with that I can respond to. So I hope you have the great rest of your day. I hope you enjoy the rest of the webinars. I believe there's 4 more in the series. So have a wonderful rest of your Monday. Take care. Bye.